Not a problem. It's a pleasure of mine to be here, and thank you everybody who's able to make it tonight. My name is Dr. Richard Zheng. I am a pediatric sleep medicine specialist here at Baystate. I work in the neurodiagnostics department, and tonight I will be giving a talk about pediatric insomnia. Primarily, talking about how we can help our children get a better night's sleep. And a lot of that will be covered with mostly behavioral insomnia, which I will go over. So the covers are the topics I'm going to cover tonight. The first question is, what is insomnia? And to be able to decide whether or not our children have it. Why is sleep important in general? And the primary issue with pediatric insomnia is primarily behavioral. And so we're going to review what is behavioral insomnia and how do we manage it, both from a parent standpoint and also from a sleep medicine standpoint. And then the biggest question when it comes to kids and sleep is about melatonin. And we're also going to cover, is melatonin safe? So the very first question is, what is insomnia? So for adults and kids, it's around bedtime. So kids generally have difficulty falling asleep, staying asleep, or they're waking up a lot in the middle of the night, oftentimes taking a while to go back to sleep, or they're waking up super early in the morning and it is hard for them to go back to sleep, and so they end up starting their day early. In kids, we typically think about insomnia starting at the age of 6 months. Before then, not all the sleep stages or cycles of sleep are completely formed yet, and so we can't diagnose a newborn with insomnia. Kids usually have resistance to going to bed on an appropriate schedule, and they typically have trouble falling asleep without the parents being involved. And that can take a toll on parents in the long term. So why is sleep important? Well, there are four main factors that sleep is important for that we know of. The first one is growth and development. Obviously, we need sleep. Our mind needs to rest in order to make memories, in order to make neuronal connections in our brain, so they can compact everything that we learned today and put it into long-term memory. And so they also need that to be able to develop, gain new skills, remember those skills. It helps improve concentration and memory during the school day, prepares them to be able to stay focused and alert during the school days to learn. It helps regulate emotions and mood, and I'm sure some of the parents out there are familiar with this. You know, if your child does not get a good night's sleep, then they're more moody the next day. They get angry often. They're a little bit short-tempered. And so getting a good night's sleep definitely helps regulate our child's mood. And when we're sick, along with getting lots of rest and hydration, it also helps our immune system get into action and fight off any infections and illnesses that we're currently having. Sleep is important for another reason, especially if your child can't sleep alone. They're always wanting to come and sleep in your bed, and sometimes our bed is just not big enough for the child. And so it can be problematic for parents and caretakers where it affects their sleep and they're not sleeping well, which then affects their mood, which then can also affect their relationship with each other along with their child. The last thing we want to do is have kind of negative feelings about our child and also regret or be pretty anxious about going to sleep, because if you know that your child's not going to sleep well tonight, you're not going to sleep well, and then that just creates a vicious cycle. So there are a lot of different factors that affect sleep in our children, starting from left to right with the orange circle. Our child's development, our child's health, their social needs, if they have anxiety, things like that, can affect our child's ability to go to sleep. at the beginning of the night and stay asleep, or even be able to be on their own if they do wake up in the middle of the night. Socially and culturally, different cultures have different norms. For example, it may be normal for a certain culture to sleep in the same bed as their child, whereas in a different culture, it may be completely normal or abnormal to sleep in the same bed as your child, and you want your child to have their own bed as soon as possible and sleep on their own. Sleep schedules are important. If a child has sports and after school programs on certain days of the week or multiple days of the week, it can definitely affect their sleep schedule. And that, in addition to school the next day, may reduce how often they're on that schedule. If they're at different parents' house, mom's house, dad's house, and grandma's house, everyone might be doing sleep a little bit differently. And so having 3 different sleep schedules can make it very difficult for a child to rotate between all 3 different schedules. And the last main factor is the sleep environment. And so where you live, so the child's home, how many kids are in the home, how many kids are in the room, and who's sleeping in the same bed as the child, all constitute as a sleep environment. And it can certainly affect whether or not a child is able to sleep on their own or able to fall asleep in general, depending on how many people are in the home and what the home environment's like. So what is normal sleep? As you guys can already guess, sleep is going to be very different depending on the age. And so this table is from the Sleep Foundation. And so obviously, the younger that we are, the more sleep that we need, because the more growth and development that we have left to do. So someone who's a newborn, from 0 to 3 months, you'll see the dark blue in the center is what is generally average. And then you have kind of what can still considered to be average, as every child is different. So for a newborn, they typically need to get anywhere between 14 to 17 hours of sleep. They can get as much as 19 hours of sleep or as little as 13 hours of sleep. And it all varies for that newborn child. And as we get older, we generally get less and less sleep. But the general minimum we try to encourage everybody for adults is 7 hours. And then every child, depending on age, is going to be different. So the 2 main factors that I'm going to be talking about tonight is behavioral insomnia. So there are 2 types. The first type is sleep onset associations. It's very common in kids who are 6 months to 3 years old. And it's essentially the child is depending on someone, something, or some action in order to fall asleep. So the most common one for someone would be, a child only wants mom and to help them fall asleep. And if mom's not there, then it's going to take a while for them to fall asleep. And sometimes they can't fall asleep until mom comes home. Something can be a favorite toy, a blanket, a stuffed animal, a pacifier. It can be very variable, and some action is probably going to be the hardest of all. So for newborns, infants who are 6 months old or older, who are breastfeeding, they will need to breastfeed in order to fall asleep. And if they wake up in the middle of the night, they just can't go back to sleep unless they breastfeed again or have a bottle of milk. Also for infants, if they're used to falling asleep being rocked or being swayed or being paced around the room and being carried, and if they wake up in the middle of the night, they can't go back to sleep until you rock them or pace them or repeat that action. It can definitely be troublesome and problematic, especially if it's 3 in the morning and all you want to do is go back to sleep. That can be very hard. And then the second type of behavioral insomnia is limit setting. So it's common in the older kids, usually 2 to 6 years old. And the biggest issue with this is they're resisting going to sleep. So they've had a bedtime. Let's say it's 7 o'clock. It's time for bed, but your child says, no, I need to use the bathroom, or I'm thirsty, I need water, or I'm hungry, I need a snack, or I need one more hug, one more story. And then there's always one more thing, and they're really fighting their bedtime. And so certainly that can be time consuming. And before you know it, it can be an hour or more of you just arguing or kind of mediating with your child. And that can be very difficult because it then eats away into their sleep time. So sleep onset associations. So things that we, kind of already covered a little bit. It's reliance on object and action or a certain person to fall asleep. Pacifier, feeding, rocking for bedtime. Mom or dad needs to be there, being held, singing, rubbing their back. Something that's more common that I'm seeing these days is that the TV needs to be on, and that oftentimes kids fall asleep with the TV on. And so if they wake up in the middle of the night, especially if there's a TV in the room, they're going to turn the TV back on. And sometimes they fall back asleep, and sometimes they find a show that they get interested in, and then they're up in the middle of the night watching TV in their room. And oftentimes, if they're old enough, parents know nothing about this until it gets brought up into one of our clinic visits. Parents learn to use a trick, and that trick is usually something that they go, if I do this, then I know they're going to fall asleep and nothing else works. I have to do this one thing. And that is usually the thing that is the dissociation. And so when they wake up in the middle of the night, they need to do the exact same trick in order for them to fall back asleep. And so not all associations are negative. Some are easier than others. Obviously, things that are objects like favorite toys or stuffed animals or blankets is something that a child can usually get on their own because it will likely be in the bed with them when they fall asleep. But things like needing to breastfeed, needing to get a bottle, needing to rock them to sleep, or singing them to sleep can be a little bit more difficult because not everyone wants to do that in the middle of the night. So what can we do about it? The biggest thing is we want to break the association so that our child is not relying on this object or this activity or this person to always need to have them in order to fall asleep. And so the way we go about that comes in a variety of different ways. So the first option is with extinction. So that is basically breaking the association outright. There's no fading, there's no slowly breaking it away. We're just not doing it anymore. And it works for some kids, and it works for some adults. The biggest issue is whether or not the adult or the parent can hold on to it, because it can be very difficult to do. And oftentimes parents get really concerned about, my child is still crying, like something is wrong, and they usually give in. And so usually extinction can be very challenging for most parents to do. The next option is gradual extinction, and we're going to talk about the Ferber method, but it is essentially we break off the association, but it gives us a little bit of leeway in there so that it gives us an opportunity to check in on our child periodically to ensure that they are still safe and to try and calm them down and not just leave them to cry on their own for the rest of the night. And then the third option is changing the association. So oftentimes it will depend on what is the thing that the child needs to fall asleep. And we slowly try and fade it out. So for example, for infants who need to breastfeed or bottle feed, and they always fall asleep while they're feeding, then we just change the timing of the feed so that when they finish the bottle, they're still awake. And so they don't associate feeding right before falling asleep. For toddlers who need to cuddle or, hugged or need to be rocked, then we try to limit the physical presence So instead of, laying in the same bed as your child until they fall asleep while you're patting their back or playing with their hair, that we start with just staying next to the bed instead of inside the bed. And we create a plan to start a stepwise process of working your way out of the room so they're able to fall asleep on their own. And then for school-age children, the 5-year-olds, 6-year-olds, 7-year-olds who are able to articulate a bit more, the biggest concern is to find out, why are they waking up in the middle of the night, or why are they having trouble falling back asleep? Is it because they're scared of the dark and they need you there to, so they can feel safe? Are they anxious about monsters? So being able to kind of open that line of communication and talking to your child and having them be able to verbalize what's going on can be an important insight into how do we work our way around it. The goal of breaking these sleep onset associations is for teaching your child to learn how to self-soothe and falling asleep by themselves. It's going to be an important skill because you don't want your child to be 8, 9, 10, 12, 15 years old and still want to sleep in the same bed as you. So an extinction. This is essentially cry it out method. You essentially have a set bedtime. When that bedtime comes, you leave the room and you are essentially, quote unquote, ignoring your child until the set morning time. This is, of course, ensuring that your child is not sick, your child's not hungry, and your child's not injured in any way before you, quote unquote, ignore them. And at some point within a week, your child will learn to fall asleep on their own once they know that no matter how long they cry for, you're not coming back to check on them. And your child will learn to self-soothe by this method. It's very effective in breaking the sleep onset associations, but it can be very difficult on the child and the parent as well, because many parents have told me that it's very difficult for them to listen to their child crying all night long. And it can definitely be challenging for people who live in apartment buildings, or if there are other children in the home or other children in the same room, can certainly be very difficult to allow this to go on for sometimes even several hours. The gradual extinction method, or also known as the Ferber method, works very similarly, but as you can see by this table, it allows the parent to periodically check in with their child. So, but it is along the lines of you just wait a little bit longer and longer in between each check-in so that it gives you the opportunity to kind of relax, and it gives your child the opportunity to also learn to self-soothe. So starting on day 1, if bedtime is 8 o'clock, as soon as 8 o'clock hits, we're out of the room and your child will likely just start crying right away. So going by this table, we wait 3 minutes before going in. We're not rushing in and tending to the child as soon as he or she is crying. We set a timer, we wait 3 minutes. We go in, the child's still crying. And when you go in, ideally you spend less than 2 minutes in the room. The goal of going in is to making sure that your child's still okay. It is not to have them stop crying. It's not for them to calm down necessarily, and it's not for them to necessarily fall asleep. It's for you to check in, making sure things are okay, allow your child to know that, see, you're still there and they're still safe. And then within 2 minutes or so, you leave the room. Some parents will pick up their child and rock them for a little bit before putting them back down, but you don't necessarily have to. And then after you leave the room, your child will likely continue to cry. And then you wait 5 minutes before you check back in. And then you continue to check in longer and longer and longer until your child falls asleep. The second day, it's the same principle, but instead of waiting 3 minutes, we're now waiting 5 minutes. And then on all the subsequent days, we're waiting a little bit longer and longer. And by the end of a couple of weeks, or within a couple of weeks, your child should be able to self-soothe and fall asleep on their own. So this third method, or the chair method, is about fading your need to be in the room. So the association is more with laying down with the parent, or needing to be hugged, or having the back rubbed, or their head patted, or hair played with, or singing a song. Um, the biggest thing is primarily going to be security. Your child just wants to know that you're there. And so with this chair method, the very first step is going to be getting out of the bed. It's perfectly fine to be next to the bed, but we don't want you staying in the bed, because if you stay in the bed with your child and they're used to having a body, next to them where it's warm, when they wake up and you're no longer there, they're going to come out searching for you and needing that warmth, whether it's going to be in your bed or for you to lay back in with them in their bed. And so we don't want to leave that association always there. So the first step is starting with a chair next to their bed with no physical contact, ideally. And if they cry and say, no, get into bed with me, it's going to be super important that you hold strong and you stay out of the bed. The following night, or every other night, depending on how well your child's doing, you're going to move the chair just a little bit further from the bed. Could be a foot, could be 2 feet. Whatever you prefer works best for you and your family. And by the end of a week or 2 weeks, you're going to be pretty much sitting right by the door, waiting for your child to fall asleep. And then the following night after that, your child will likely be able to fall asleep with you, even being in the room with them. And the key thing with every single one of these methods is going to be consistency, is that we don't just try one night or 3 nights or 4 nights and then just give in. We want to stay consistent for at least up to 2 weeks, and you will be impressed with how well your child can do. Certainly, it's not going to be easy to be consistent, but it will be the key to your success. The second type is going to be limit setting. So again, common in our older kids, 2 to 6 years old. And oftentimes they struggle with bedtime specifically. The middle of the night is not so bad, but it's always getting them to bed that's particularly difficult. And so we talk about repetitive current calls. There's always one more thing that they want. And it can definitely be hard for parents to say no, because especially if a child goes, I'm hungry, you don't want your child to go to bed hungry. And so you'll always likely give them a snack or give them a drink, or lead them to the bathroom because you don't want nighttime accidents. So it is particularly difficult. And it can take a little bit of time to realize that, they don't necessarily need all these things. And it's just them wanting to stay up a little bit longer and have a fear of missing out because everyone else is still awake and not going to bed at the same time. So what do we do? The important thing is to have a consistent bedtime and a bedtime routine. So everything's on a schedule and they know what to expect. You can utilize a bedtime routine chart, and we'll get into a little bit about why that's important. You can even create a pass system, so kind of a trade-off, so that it provides a limit for your child in terms of how many things they can ask for. And again, key thing is for parents to stay firm and consistent. So a consistent bedtime routine, we want to make sure it's appropriate for age. So something that's appropriate for a 6-month-old is going to be different for something for a 15-month-old, and that's going to look a little bit different for someone who's 3 years old or 5 years old. The duration of the bedtime routine should always be about an hour or less, and it should consist of about 3 to 5 activities. So a good bedtime routine always works towards the bedroom, and oftentimes I'll have patients who come in who say, we start a bedtime routine right after dinner. It's usually a shower, they brush their teeth, they get into PJs, and then they come downstairs and they watch a movie and they wrestle with their siblings, and then they eat a snack and get a drink, and then they go back to their bed at this time, and then we expect them to go to sleep. That is not an ideal bedtime routine because one, there's too many things in there, and two, it's too stimulating. Um, Once we start a bedtime routine, we want things to get less and less stimulating over time, and we want to have it end with them falling asleep in their bed. The parents should definitely be involved with the bedtime routine. We don't want them to, take their shower, brush their teeth, they go in their bed, and then they're on their cell phone for the rest of the night, or they're then watching TV for about an hour and a half in their bed alone. That's not a good bedtime routine. One, it's not specific enough because kids will just fall asleep whenever they fall asleep. And then two, our kids are left unattended, and we don't want that to be, a gateway into potential, getting in trouble. We don't exactly know when they fall asleep. We don't know if they're waking up. We don't know if they're watching TV for 5 minutes, 30 minutes, an hour. So we definitely want the parents to be involved, and it's good bonding time for parents and their kids as well. So a bedtime routine chart looks something like this. It can be stickers. It can be check boxes that you check off. But we want something to be visible inside the bedroom so that the child and the parents can refer to it. And the way it helps with limiting certain things in the night, and we're not constantly asking for more things, is that you can simply blame the bedtime routine. It's difficult for parents to say, no, you can't have this, or no, you can't have that. But with a bedtime routine and having a bedtime routine chart, you can simply point to this chart and say, no, we can't have, a glass of water. We can't have milk. It's not a part of your routine. What's the next thing on your routine? It's bedtime. You can have, your water when you wake up in the morning. And so you can simply use your bedtime routine chart to be the end-all be-all culprit of it, and put the responsibility on that. So it's not you saying no, it's just not in the bedtime routine chart. Okay. The next thing that can potentially help is using a pass system. So creating a pass system can be something that you and your child can do together. It could be made out of construction paper. It can be stickers. And it doesn't have to be anything complicated. So you can limit your child to 1 to 3 passes, probably start with 3 and then limit over the next few nights. And every time they request something, you can request that they hand over a pass. And when they run out of passes and they're still requesting, you can say, oh, you don't have any more passes. I'll give you more passes tomorrow night. It's time for bed. And again, you are not the one saying no, you're blaming the system of having a pass. It does not need to be anything complicated. It could be pieces of paper. It could be construction paper. It could be stickers. I had a family who was using tokens or quarters, and using, if they don't use a quarter, it goes into their piggy bank. And if it goes into their piggy bank, then it can go, they can get a toy from the dollar store at the end of the week or at the end of 2 weeks. And so that sometimes can be a little bit more complicated because a child, one, needs to grasp the concept of money and the value of money. A child needs to grasp the concept of saving. And then a child also needs to grasp the concept of end of the week. Typically, for children that have these limit setting problems with bedtime, they only care about the here and now. They don't care about 5 days from now. They don't care about 2 weeks from now. And sometimes the concept of something that's going to happen or reward in a couple of weeks can be a very hard thing to grasp. And it may not be as motivating as we think it could be. So heading towards, the end of tonight's talk, parents always want to know about melatonin. So as of right now, there are no FDA-approved medications for sleep specifically. There are certainly medications out there that can be used in treating other conditions that have the side effect of making kids sleepy, but there are no medications that are used specifically to help kids sleep. And especially no medications to use in children who are less than 5 years old. But there may be some exceptions for kids who are atypical in terms of development. So kids with autism, kids with certain genetic syndromes, kids with ADHD have a little bit more trouble falling asleep. I would still start with finding out what their association is, establishing a good bedtime routine way before jumping to using medications to help them sleep. And again, medications are more band-aids, right? They are used to have kids fall asleep, but they're not necessarily addressing certain factors. And so we definitely don't want kids on medications for sleeping specifically for long periods of time. It can certainly affect their ability to function during the day. Oftentimes, sleep medications can make kids overly groggy and hard to wake up in the morning. And with all forms of medication for kids and for adults, they're only effective for short term. And over time, your body will get used to these medications and they will just stop working or be less effective. And the decision points at that point that I always counsel all my patients who are on medications or thinking about medications is you either go up on the dose or you switch to a different medication and you repeat the same process. And so by not addressing the main factors for why we can't sleep or why our child's having trouble sleeping, we're only putting band-aids and not solving the actual issue. The other key thing is melatonin here in the US is not regulated by the FDA. It is deemed a supplement and it is not a medication, which is why you can buy it over the counter. And they come in various different forms. There's so many different companies that make melatonin. Zarbee's is a common pediatric brand. You see Natrol, there's some CVS generic brands, and then you see Nature Made. And so before starting a child on melatonin, I would definitely speak to your pediatrician first and asking whether or not melatonin is a good idea for your child. And with it being a supplement and not regulated by any governing industry, there have been publications out there that show that if a bottle says there is 5 milligrams of melatonin in it, there's a good chance that not every tablet in that bottle is 5 milligrams. The study has shown that some have been more than 450% than what is 450% dose higher than what is on the bottle. So, even though the bottle says 5 milligrams, some may be 10, some may be 15, some may be 20, some may be even less than 5, and some may be 2, some may be 1. And so not every tablet is the same because it's not regulated and they're not tested. The other thing is melatonin may not be the only ingredient, even though that is what it's supposed to be on the bottle. Some have found serotonin mixed in. Some have found THC, cannabinoids, marijuana mixed in. And so melatonin, since it's being sold as a supplement, is not entirely reliable. So I would not go out and buy a bottle and just start giving it to your child. But if you do decide to give it, I will say the most effective dose, or not most effective dose, I apologize. The dose that would be considered high would be 5 milligrams. And I would definitely not go past 5. And studies and research has shown that melatonin is not more effective past 5 milligrams. Even 1 milligram is way more than what our body is already naturally producing. And there is a very common misconception about melatonin. We usually think that by using melatonin, it will put us to sleep. And that is not the case. Melatonin, when naturally made in our brain, gives us a clue, a hint that we should be getting tired soon, that we should consider going to sleep soon. And by giving us more melatonin, it does not necessarily knock us out or put us to sleep. it just strengthens that signal. But if your child is playing on their phone or watching TV, giving 5 milligrams of melatonin does not overcome that. Okay. So it is important to address those factors beforehand before jumping to melatonin or any other medications. So the key takeaways from tonight's talk is that sleep is important. You want to make sure that your child's getting the recommended amount of sleep for age, because every child's different. So you don't want your 1-year-old to be sleeping the same amount as your 15-year-old, or vice versa, actually. You want to establish a bedtime routine. It sets the night up to allow your body and your child's body and their brain to signal to them, all right, we're doing calming activities. It's time to unwind, and bedtime is coming soon, and it will allow us to fall asleep. It is very hard for us to not have a bedtime routine and to go from watching TV, watching something scary, playing on our phones, wrestling with our siblings, to then expect to do a complete 180 to, all right, turn off your brain and go to sleep. It doesn't work that way. And it's very difficult to have that expectation for our child. So we want them to give them time to unwind, and that bedtime routine should take about an hour or less. For sleep onset associations, we want to teach your child to self-soothe. So it's an important life skill to be able to sleep on their own and fall asleep on their own. And for limit setting, we want to I want to empower you as parents and caretakers to be able to set the boundaries for your child and not give in to all of their demands. As you know, that it will be important for them, and in the long run, it'll be important for you to be able to get a good night's sleep for yourself as well. These are 2 websites that I always recommend for my parents to take a look at. Not only for sleep, for other things as well, but they're good websites to learn about sleep and what is healthy sleep. And so the first one's kidshealth.org. It is made by Nemours Children's Hospital in Delaware. And then healthychildren.org is a very good website where they get a lot of their information from the American Academy of Pediatrics, so the governing body for pediatric health. And so I highly recommend parents take a look at those websites for sleep questions, as well as any other questions that they have about growth and development for their kids. And that is my last slide. So I'll take any questions that anyone may have.
Thank you, Dr. Zheng, for that great presentation. I loved your content on strategies and really smart stuff. So thank you for your expertise. So if anyone has any questions, you can type your questions into the Q&A box for Dr. Zheng, and we'll just kind of give everyone a minute to type those in, although the topic was brilliantly covered. I don't know if there's any questions. Oh, there is one to start.
Mm-hmm.
How do you best soothe a child after a bad dream?
How do you best what? Sorry?
Soothe a child after a bad dream?
Okay. No, that's a very good question. So I would say after a bad dream, it's going to be super important to just try and help and calm your child down. Oftentimes, parents will go in with questions about what did you dream about? Was it scary? I think the biggest thing is just to reassure your child that it was just a bad dream. They're safe. You're there with them, and it's okay to go back to sleep. If it is certainly a reoccurring dream, though, like nightmares, I would definitely recommend the following morning to talk about the bad dream or the nightmare when it's bright out in perfectly good sunlight and there's nothing scary about your environment, to just walk through the dream and reassure them, again, it's just a dream and it's safe. Oftentimes, kids will feel better once they've been able to talk it out, but you don't want to talk it out in the middle of the night because it's still dark and you want them to go back to sleep. So you don't want them to dwell on it. But when they talk about it in the morning and you're reassuring them, it typically makes them feel better. And if they do have that dream again, sometimes they're able to just self-soothe and go back to sleep without necessarily needing your presence there all the time.
Oh, I was on mute. Excellent. Thank you. So we have a couple more questions.
Sure.
Their 4-year-old is very restless sleeper, and that often causes her to wake up. And then she wants to sleep in our bed and doesn't want to sleep alone. Anything we can do?
Yeah, so kids being restless sleepers is actually a very common thing. I hear about kids who toss and turn all night long, but they're still asleep, or kids who are completely upside down by the time they wake up in the morning, or pillows are on the floor, or blankets are on the floor. What I would say is if your child's a restless sleeper, I would try and see, is there something that makes them restless? If they've always been restless sleepers, it's just the way they are. There may not be anything that's specifically wrong, but the fact that they do wake up is not necessarily the problem. It's the fact that they come to your room instead of falling back asleep. That is the problem. So I would pay close attention about the sleep onset association. Why do they want to sleep in the same bed as you? Is it because you're in the same bed as them when they fall asleep at the beginning of the night? Or are you right next to them when they fall asleep at the beginning of the night? And that's what they need in order to go back to sleep. So that would be something important to address as well. If they simply just want to do it without any of those onset associations, then it's probably just from a behavior standpoint, something that your child wants to do. And so then it is your decision as a parent, well, do I put up with this? And is it okay? Like if you're okay with your child sleeping in your bed in the middle of the night, then there's nothing wrong. But if you're like, I don't want to be woken up every night by my child and them crawling into bed and I'm, on the edge of my bed or having to sleep on the floor or something of that nature, then I would strongly advise you to always bring your child back to their own bedroom and have them fall asleep there without climbing into bed with them or repeating that association. Because essentially it's your persistence versus their persistence. And as a parent, your persistence ideally should always win. It may not always be the case, but when they know that if they just come to your room and they're going to get walked right back to their room, then they may just stop coming to your room.
Excellent. Thank you for that. The next question, do you see children with autism? My 4-year-old son with autism will wake up at 2 a.m. and stay up sometimes until 2 p.m. We do not really want to heavy medicate him.
Yes, I do see kids with autism. I see a number of kids referred to my clinic from the neighboring pediatricians with the same, similar story of having trouble falling asleep or staying asleep or going back to sleep. A lot of the stuff that we talk about is going to be the information that we talked about tonight. But kids with autism and ADHD and other, neuro atypical development have a harder time sleeping. They're just at higher risk of developing insomnia. And so we can definitely have that conversation when I see you in clinic to dive deep, to dive a little bit deeper to see what's going on with that.
Thank you. We have a couple more questions.
Mm-hmm.
I have 8-year-old twin girls. I'm struggling with getting them to stay asleep as they wake each other up at times. And I'm trying to wean them off electronics. And then there's a further note when to get off electronics, what she was, I guess, trying to say.
Yeah. So twins definitely, or any two children or more sleeping in the same room, kind of have this potential positive or negative feedback loop where they kind of keep each other awake. So what I would advise with beginning of the night is having a solid bedtime routine that they both can do, whether it's both in the same bed or in a neutral area in the middle of the room, where they can have a story time or listen to music or, whatever fits into your routine. But in terms of the electronics, I would start with a hard cutoff, and I would actually start with the cutoff of electronics before you start the bedtime routine. So, if their bedtime is 8 o'clock, then bedtime routine should maybe start around 7 o'clock. And that's when the electronics end, and that's where the wind down period starts. And so there is no electronics in the bedtime routine. You could do story time. You could have them color, draw, read their own stories since they're 8 years old. And you can have them take turns picking out the book and who's going to read the book and make it more of a family matter. And so by their bedtime, they should start to get more tired, more sleepy. And it's okay if they're not asleep by the time everything ends. You can say, all right, this is the last story, lights out after this, and leave the room. Electronics is very hard these days, given how easy and accessible it is. But I would start with the bedtime routine and stopping all electronics right when the bedtime routine starts.
Excellent. Thank you. Next question. Is it okay to have your child sleeping in spaces other than their bed in their room, maybe under the bed or on a rug, etc.?
So I would say if long as it's safe, it's clean, and there are no concerns about things falling, then I would say that your child does not have to sleep in a bed. Now, what I would caveat that with is, why does your child not want to sleep in the bed? Is it because it's too hot? Is it because it's too cold? Is it because it's too soft? It's too hard? Knowing kind of why your child does not prefer to sleep in the bed can kind of help us tailor in. Do they have sensory issues? Are there ways that we can accommodate, like with a fan or AC or something, to get them to sleep in the bed? But if they sleep, on the floor or on a rug perfectly fine, and you're okay with it, then I'm okay with it.
Those were great suggestions too about finding out why. That's great.
Yeah.
The next question.
Mhm.
I have a 1-year-old and another one on the way.
Mm.
At that point, I will have a 1.5-year-old and a newborn. Is it better to have them sleep in the same room, or can that be disruptive to each other's sleep?
I will say that depends on what you prefer, and also whether or not you have the availability in your room for your 1-year-old to have their own room. So it really boils down to like how much space is available for you. I would say in a sense, it may be disruptive in the sense that if you have a newborn who needs to likely feed every 3 to 4 hours throughout the night, and you need to enter the room, it could potentially be disruptive to your 1.5-year-old for sure. But oftentimes, depending on you, some parents will have a newborn stay in the parent's bedroom, so they don't need to walk, to a different room to feed their child in the middle of the night. So, you know, it really varies on how soon you plan on having them in the same room. I will say this though, if you plan on having your 1-year-old go into a different room or transition to a new bed and the newborn is taking their old room, I would do that at least 3 to 6 months before your newborn is born so that your child does not feel like they're being kicked out of their bedroom just to make space for your newborn, and get a sense of jealousy and kind of more disruptive behaviors. So you can focus ahead of time, 3 to 6 months. Hey, you're a big boy now or a big girl now, and you can, transition to a bigger bed, or here's a bigger room, and kind of celebrate that, and not, we're moving you out because we got to make room for this newborn baby, and now we're transitioning the old room into a nursery again. That would be one thing that I would definitely recommend. But whether or not they sleep in the same room, I think it really depends on what your plans are once your newborn is here.
That was a really perceptive suggestion on your part, right?
Yeah.
To avoid the jealousy. What a good
Mhm.
point. So thank you.
Yeah,
We just have, looks like two more questions.
sure.
We're trying to get our 1-year-old son to self soothe himself to sleep when he wakes up in the middle of the night.
Mhm.
Is it counterproductive to hold him so he relaxes and stops crying?
I would say if we're trying to get him to self-soothe, it may be a little bit counterproductive to hold him. Now, it is not wrong to hold him, but the concern that I may have is that if he is frequently waking up in the middle of the night and he is comforted by you holding him, um, that may be the thing that he looks for every single time he wakes up in the middle of the night is for someone to hold him to soothe him. Um, but at the same time, I don't want to say, no, you can't hold your child, because you're the one who is, it's your child. So granted, I'm not the one staying at your house that needs to comfort your child. So if it helps your child soothe faster by holding him, then by all means do it. But I would not hold your child to the point where he falls back asleep. So it's okay to hold him, soothe him, get him to calm down, and then go, everything's okay, you're safe, we're here, it's time to go back to sleep, and then allow him to then fall back asleep on his own. You can use things like his favorite toy, or his favorite stuffed animal, or his favorite blanket, or something that he holds dear that he finds comforting, that can soothe him, that he can use to soothe himself and not maybe always require you to be present to soothe him. And you can say, here's your favorite toy. He's safe. It's time to go to sleep for both of you. Things of that nature can certainly be helpful. And some of the stuff, it has to do with what is your tolerance level and what is your preference in terms of how much we do or do not do.
Excellent. Thank you.
Yeah.
This looks like it's the last question.
Okay.
And what do you recommend, or what do you do about sleepwalking? What's the best way to bring them around?
Yeah. So for sleepwalking, depending on how old your child is, but the general um, recommendation or guidance I give for any child that sleepwalks is number one, you want to make sure that their environment is very safe. Because when a child is sleepwalking, they don't know they're sleepwalking. They're obviously sleeping. So you want to make sure that there are no sharp corners or sharp objects in the room that they could potentially bump into or pick up and throw. You want to make sure there's nothing on the floor that they could potentially trip over. So like rugs, toys, cords, things like that. And number three, on top of all that safety, you also want to ensure that you have baby gates in front of stairs. You certainly don't want your child walking up or downstairs while they're sleepwalking. And then you also want to have alarms of some sort to doors leading to the outside. Because even if doors are locked, your child can certainly unlock doors in their sleep and walk outside. So you want to have alarms or bells. What I recommend to my patients is if their child is sleepwalking frequently, you want to have some bells on their bedroom door, on the doors that lead to the outside, so that when they're opening doors in their sleep, then they are either alerting you, so you hear the bell and that they're up and walking, or the ringing of the bell wakes them up and they know they're walking and they just go back to bed. But one of the important things is if you find your child sleepwalking, do not wake them up. Do not try to call their name. Just take their hand and guide them back to their bed, and they'll likely just follow and go back to sleep. If you try to wake them up by shaking them, yelling their name, things like that, it can make these episodes last longer, and it can also get them more aggravated and upset, which leads to a harder time for them to get back to their bed. So if you see them walking, just guide them back to their bed and make sure they don't have access to any sharp objects either in their bedroom or in the kitchen or around the home, because we don't want any injuries to happen when they're sleepwalking.
Great tips and great information, Dr. Zheng. Thank you very much for your time and expertise tonight. And thank you to our attendees for joining us. Really great questions.
Yeah. All right. Thank you, everybody.